Hello, my name's Kim. I'm one of the cardiac rehabilitation sisters at BHRUT, and today I'm going to be talking about understanding your heart. So it's a bit of an anatomy and physiology session. So the aims of the session are to understand the basic anatomy and physiology, be aware of what can go wrong, understand the different cardiac procedures and different diagnosis, recognise chest pain and what to do, and there's a couple of interesting facts at the end. So first of all, how big is your heart? Well, it's actually the size of your fist, approximately. So where is it located? It's under the sternum, which is the breastbone, and it slightly points to the left, so it doesn't sit up straight. The heart slightly points to the left. So what is your heart? Well, it's a muscle and it's a pump. So what's it pumping? It's pumping blood, oxygen and nutrients throughout your whole body. Any idea how much it might weigh? It's approximately 310 grams or 11 ounces. Now the heart has three layers. The pericardium is actually two very thin layers around the outside of the heart, and it covers the heart. And between those two layers is a tiny amount of fluid. So as your heart beats, you don't feel any friction. The endocardium is all around the inside of the heart, and it covers the lining on the whole of the inside of the heart. And the myocardium, well, that's the main muscle of the heart, and that's where the electrical conduction goes through. So that's the main crux of the heart there. Now the heart has four chambers. I wonder if you could name them. There's the right and left atrium, and there's the right and left ventricle. Between the atrium and ventricles are the valves. So on the left hand side we've got the aortic valve and the mitral valve, and on the right hand side we've got the pulmonary valve and the tricuspid valve. Now sometimes these valves can become a bit loose and floppy, or they can become stiff and stenosed, and the treatment for those can be a replacement or a repair. So a surgical repair, they would just cut out a little triangular section from the valve and basically stitch the two edges up together so it tightens the valve. Sometimes they can put a ring around to tighten the valve. The surgical replacement, now a lot of people will say a metallic replacement, but it's actually made of carbon fibre. And there are three different replacements. The three different replacements can be a tissue valve or the mechanical valve, and on the screen you can see three different types. So the tissue valve will come from either a pig or a cow, so that's a bovine or a porcine valve, and they usually last about 15 or so years. But with a tissue valve, the body doesn't reject that valve, and therefore you don't need to be taking a medication like warfarin, a very strong anticoagulant that you would have to take if you had a mechanical replacement. So if you look at the St Jude valve and the Starr-Edward ball and cage valve, apparently I'm told they look a little bit like plumbing instruments, which I suppose is what they do. So as the blood flows through with the Edwards ball valve, the ball would go up and then it would come down as the heart was pumping. Now mechanical ones should last a lifetime. So even though you have to take a strong anticoagulant when you've got a mechanical valve, you know that the surgery isn't going to have to happen again. Whereas with the tissue valve, there is occasion that you might have to have repeat surgery. So when we look at the cardiovascular system, the cardiovascular system is basically circulating oxygenated blood to the tissues, and then it pumps the deoxygenated blood back to the lungs. So as the blood comes out in the capillaries, it's full of oxygen, nice rich oxygen blood, goes through to all of the organs. As the oxygen depletes, the blood will go across the capillaries into the veins. And when it gets to the veins bring the blood back up to the heart, onto the right hand side, and then over to the lungs, where it will now collect more oxygen rich blood back in through the left side, and so that cycle continues. So things that can go wrong, the fatty deposits called atheroma can develop in the arteries, and if you look at the picture there, the artery becomes narrowed and the blood flow is restricted. So it can narrow right down so that the blood is hardly getting through, or it can actually close right over. And the atheroma is actually very hard. It's very much like the plaque of your kettle. So if you imagine it in your artery, a little bit can stick up, and then as the blood flows through, it hooks onto that little bit sticking up, and then the platelets collect, and that will cause a clot. And then by blocking the artery with that clot is what can cause a heart attack. Now, you might have heard of angina. So what is angina? There's different types of angina. You've got stable angina. That is predictable. It occurs on exertion and it's relieved with rest or with your GTN spray. And I've got a little picture there showing a man running for a bus. So he's strolling along the street, he sees the bus coming, suddenly puts on a big spurt of energy to get the bus. When he gets on the bus, he sits down. So as he's exerting himself, he will get that angina type symptom. And I'm going to talk all about the different symptoms of angina. But stable angina is predictable and relieved with rest or GTN spray. Unstable angina is unpredictable. It can occur at rest and it isn't often relieved by GTN spray. So unstable angina is what is likely to bring people into hospital. Now, when we talk about angina or cardiac symptoms, most people think of pain in the chest coming down the left arm. That can be a symptom, but it can also be coming down the right arm. It can be coming across the shoulders, up the neck, down the jaw. It might be more like a crushing or heaviness or burning sensation, or like you've got a little baby elephant sitting on your chest, or a belt tied tight around your chest. It could be that you've got no pain at all. You might feel just very sweaty, clammy, sick, looking quite grey in colour. You might actually be sick. You might be very short of breath. All of these signs can be a symptom of angina. So a symptom that there is not enough oxygen-rich blood getting to the muscle of the heart. So what do? You stop what you're doing. You sit or lie down. If you have a GTN spray, you use 1 or 2 puffs under the tongue with the spray. Then you can wait 5 minutes, and if it still hasn't gone, whatever that symptom is, if it still hasn't gone, use the spray again. But if it still doesn't go after another 5 minutes, you dial 999. There's no other number to dial. It's 999. If you do not have a GTN spray, then you stop what you're doing, sit or lie down for 5 minutes. If it's not gone within 5 minutes, you dial 999. Now, the GTN spray actually relaxes the artery walls. They're muscular, and by using the spray, it widens those walls by relaxing those muscles and lets a good amount of oxygen-rich blood through to your heart muscle. Not does it only work around the heart, it widens the arteries over the whole body. So that's why we suggest that you sit or lie down, because it can make you feel quite dizzy and unwell, and it does drop your blood pressure. If you've used the spray and you feel dizzy or lightheaded in any way, please do not continue to use the spray. If the symptom doesn't go, you just dial 999 straight away. So the difference between angina and a heart attack would be where the arteries become blocked. So when I was explaining about the clot forming on the little bit of plaque that sticks up, when the artery becomes blocked or it's so narrow that hardly any blood can get through, then that's what causes a heart attack. And what happens is the muscle of the heart is actually starved of oxygen. So that can cause permanent damage to the heart muscle, which, as we know, is the pump of the heart. And that can lead on to heart failure. So if we look at the anatomy of a heart attack, you've got a nice pink heart on one side, and on the other side you've got one with a bit of a bluey haze to it, and that's where the artery is blocked and everything the other side of that artery is not receiving its oxygen and nutrients, and in effect that muscle is starting to die. So it's always quick action if you think you've got anything going on with your heart. Now, with the arteries, there's lots of abbreviations, and some of you would have gone home with your discharge papers that have got all these abbreviations that you might not quite understand. So we look at the abbreviations with the arteries of the heart. So the LMS is the left main stem, and that's the first part that comes off of the main aorta. So with your heart, the aorta is the first artery that comes out, and the left main stem is the first one that comes off of that. That's considered to be the main artery of your heart on the outside, and that goes down into the left anterior descending artery. Now, what that left side artery does is it supplies the front surface of the heart and the left ventricle with all its oxygen and nutrients. Coming around the back is the circumflex, so that would be down as a CX or LCX in some cases. And that's quite a small artery, but it goes around the back of the heart and supplies the back of the heart with this oxygen and nutrients. On the right side, you've got the right coronary artery, and that comes down and supplies the bottom surface of the heart and the right ventricle. And you'll see on the left-hand side that you've got quite a few more bigger arteries than on the right-hand side. And these are not the only arteries around your heart. Your heart is smothered in arteries and veins and capillaries. It's like a spider's web all over, but these are the main ones. And the reason you've got more bigger ones on the left-hand side is because that's the main pump. So from the left-hand side, the blood is going around to every organ of your body. From the right-hand side, it's just going across to your lungs. So we can treat narrowed arteries with a stent. So a stent is a tiny metal coil made of titanium. It looks a little bit like the spring out of a biro, and it should last a lifetime. That is the idea. Now, when you have your angiogram, which is the procedure whereby they put the stent in, they usually make a little incision in your wrist, and then they will pass a tube up through the artery that goes to the heart. They identify the narrowing by inserting a dye and looking at it under an X-ray machine. Once they've identified where the narrowing is, they can then put in the stent. So the stent is tiny, flat, with a balloon underneath it. And as it goes through the artery, when it gets to the area of narrowing, they inflate the balloon, which pops the stent open, basically squashing the narrowing to the sides. They deflate the balloon, take the tube out, but they leave the stent in. So in the picture you can see the artery is now slightly wider where they've extended that stent. And that stent then cannot move around because it is slightly larger than your artery. What happens over a period of time is the artery will grow around the stent and make it part of your structure, so it incorporates it into your body. So although it's a bit of a foreign body first of all, it does become part of your structure. So you couldn't go in 6 months' time and take that stent out because that sort of growing around it has already started. Now, if they can't put a stent in, then they will sometimes do a treatment called rotablation. And if you imagine, that's like a tiny drill bit. Goes in exactly the same way, up through the artery to the heart, but it whirs around. It looks a little bit like an acorn type thing. And it whirs around and breaks down all that hard atheroma in your arteries. Now, they don't suck all the little bits out. Apparently the bits are extremely small and they just dissipate into the system. But by making that little area wider, they can then go in with a stent. It's not a common procedure and it does have quite high risk of bursting the artery. So it's not something that they would do as a first choice, but it is an option if they can't get through to put the stents in. Now, if stent or rotablation can't be done, then what's the next treatment option? So it's a CABG. So that's a coronary artery bypass graft. It's not what you have with your Sunday roast, but it's quite a long mouthful, so we always shorten it to CABG. So what they're basically doing is bypassing one of your coronary arteries with a graft. So they identify where the narrowing is. If there's only one narrowing, then they will use an internal artery, which is the left internal mammary artery, and they will disconnect that from the rib end because the left internal mammary feeds the ribs. Disconnect it from the rib end, make a little incision just below the blockage, and they reattach that graft underneath that blockage. So although they don't take out the artery that's narrowed, there might still be a little bit of blood flowing through there. The main supply now comes lovely down via the graft. If it's only one, it may even be keyhole surgery, but usually it's more than one. So it could be 2, it could be 3, it could be 4. I've known as many as 6 grafts in one go. But to take the grafts for the more than one, they need to take a vein, and they usually take the vein out of your leg. So generally the scar for your leg vein will come from your ankle right the way up to your groin. If you're lucky, you might have tiny little incisions all the way up, or they may only go up to your knee. If you're very unlucky, it could be both legs. And if they can't get a good vein from your legs, they'll then go to your arms, and they can go up both of the arms as well. But they need a good piece of vein that is nice and clear to be able to do the graft. So then they will make a little incision at the aorta again and attach the top end of the graft, and then again below the blockage to attach the bottom end of the graft. Now they do check with the veins, because the veins have got one-way valves in, because remember, the veins are bringing the deoxygenated blood back up to the heart. So they do make sure they've got it the right way round, so that the one-way valves don't block the new grafts. Now your graft can't come detached, it's stitched, it's sometimes glued. They do have to go through the breastbone, so they do have to cut through that breastbone, and they fix that back with wires and staples, so it is really very strong. Sometimes it's known as the zipper club when you've had a bypass, because if you look at the picture on an X-ray machine, it looks like a zipper because you've got all the little lines of the staples that you can see. Obviously recovery time does take a while, and it's a good up to 3 months before people fully feel back to normal, and for some people it can take even longer, it can take up to a year. But it's a slow process of recovery, and it's just sort of protecting the wound and allowing it to heal. Although more people tell me that they have problem with their leg wound than they do with their chest wound, but everybody's individual. There are other cardiac conditions. Atrial fibrillation is one of the most common ones, so known as AF. We tend to get that as we get older, unfortunately, but also some people, if they have a chest infection or a urine infection, they can get atrial fibrillation, and it can just be a one-off, or perhaps just occurring now and then rather than a continual atrial fibrillation. And what it is, the top part of the heart is just going too fast, whereas the bottom part of the heart is going along nicely. So when the top part of the heart is going too fast, you're more at risk of little clots forming because the blood isn't going through properly. And those little clots can then travel around your body and cause havoc. They can cause strokes, they can cause clots in your leg, they can cause heart attack. So atrial fibrillation, one of the common signs might be palpitations, shortness of breath, or feeling dizzy. The treatment is usually with beta blockers, so drugs that can help slow your heart rate down, and also anticoagulation, so blood thinners, things like warfarin, and there are newer anticoagulants that are sometimes used as well. Ventricular fibrillation is a completely different story. That's when the bottom part of the heart is just doing this, and that is not compatible with life. So when people talk about heart attack, they think that if you clutch your chest and fall to the floor, that's a heart attack. So when we see patients who've had heart attacks and haven't had that, they find it hard to believe they've actually had a heart attack. What we're describing is a cardiac arrest, and that is a life-threatening condition, and it is completely different to a heart attack. Although it can be caused by a heart attack, it can also just be caused by an abnormal rhythm. The emergency medical treatment for that would be defibrillation. Also, it would be chest compressions. So with the defibrillation, what happens there is the two pads go onto your body, and they put a very small electric shock through, and it actually stops the heart, which allows it time to regroup, if you like, and then start pumping back at its normal rate. So anybody having a cardiac arrest, it is a medical emergency and it needs treatment straight away, but don't get it confused with a heart attack. Other procedures could be a pacemaker or an internal cardiac defibrillator. So a pacemaker is when your heart rate is really low. So when you go through your heart, you've got little nodes that set the conduction of the heart beating. And if they are out of sync or not working, then the heart will beat at a very low rate. Now, normal heart rate is between 60 and 100, and anything in that range is normal. A lot of our heart patients will be on the lower end or in the 50s because of their medication. but somebody coming along with like a 30 or 35 heart rate is going to want a permanent pacemaker. And what that does, it just gets the heart to work at around 60. It's a box about so big, and it's just put under the skin. So they make a little incision under your shoulder blade, make a little pocket and slip the box in, and the wires go through to the heart. Now, if you've had a cardiac arrest and it's not secondary to a heart attack, or your heart is regularly going into an abnormal rhythm, then they can put in an internal defibrillator. So where you will be defibrillated with big pads on the outside, this time the box is bigger than a pacemaker box, but it still goes in the same area, and it senses if your heart is going too fast. And if it gets to a certain level, it senses that and gets ready to shock. And it puts a shock of about 15 kilojoules through the heart. And again, it does the same procedure as the defibrillator pads on the outside. Some people feel it and say it feels like a bit of a kick from a horse. Other people don't feel it at all. Some people, it never ever goes off. It's in as a precaution and it never has to go off. So that's the internal defibrillator and what that does. So a couple of the abbreviations on the screen, we've already mentioned a few of them, the left main stem, the circumflex, the right coronary artery. We do have different types of stents. There's a drug-eluting stent, which is a coated stent, and a bare metal stent, which is just a plain stent. Usually the drug-coated stent is used, and it's used because it tends to bed into the artery a little bit better, but the drug coating can cause a little bit more inflammation. So you'd usually be on a tablet like clopidogrel or ticagrelor or prasugrel. That keeps your blood a little bit thinner to prevent those clots from forming around the stent as it beds into the artery. Left ventricular ejection fraction, well, that is the pumping action of the heart. So they're looking at how the heart pumps, and normal reading is 55% or above. So on your paperwork, you might find that there's a percentage written there. But remember, normal isn't 100%, normal is 55% or above. If your heart is pumping at 30% or lower, it is considered to be quite poor. But what we find when your heart has a heart attack, it is in shock, and it takes a good 6 to 8 weeks for your heart to recover. So we would always suggest that your GP checks your heart function again after that period of time to see how it's improving. And the left internal mammary artery, we've already spoken about, they're used for the bypass. So the different procedures, the electrocardiogram or ECG is just where they put the stickers on, and the machine reads what your heart is doing. If there's a heart attack going on, we can see on the machine. If you've got symptoms of a heart attack, we can't see it on the machine, then it may be that the heart attack is not affecting the full thickness of the heart muscle. If you've still got the symptoms, you'll come to the local A&E and you will be checked out, and we'll be checking for a blood test. The blood test that we check for is called troponin, and it's a protein that's released by your heart if it's under any stress. So if you've got symptoms of a heart attack, but no show on the electrocardiogram, but you've got the raised blood count, then you'll be treated as a heart attack. The echocardiogram is the one where they do the jelly scan over your heart, and that shows us the function of your heart. But you can also see how the valves are working. And the transesophageal echo is very similar in that it looks at the function of the heart and the valves, but it actually goes down your throat, so it looks much clearer at the back part of your heart. The myocardial perfusion scan and the cardiac CMRI, they are ones where you go into the tunnel and you usually have a dye, and they can see how the heart again is functioning and how well the dye is taken up into your heart muscle. So we're looking at how well the blood is going to your heart muscle. So just some facts, about 280 people per day are admitted into hospital in the UK due to a heart attack. So that's actually one person every 5 minutes, according to the British Heart Foundation. Now, if your heart beats at 70 beats per minute, it will beat 100,800 times per day on average. And in the 2015-16 statistics at the NHS, £2.6 billion was spent on cardiac care. A bypass approximately costs about £22,000. The ICD, the internal defibrillator, between £10,000 and £16,000. A heart attack overnight stay, usually about 2 days stay now, is about £2,500 on average. In some private hospitals, to have an angiogram on just one stent can be over £9,000. And a drug-eluting stent as an emergency procedure is £3,500 for that one procedure. To have an ECG is about £90 each time. When you're in hospital, you'll have an ECG every single day. And the echo scan is about £195. Heart transplant, approximately about £44,000. So I know we're not really interested in the figures, but it just shows you how much is spent on cardiac care. So please take care of your heart.